In the last decade, we've seen major improvements in the outcome for patients with metastatic colorectal cancer, which are mainly linked to not necessarily advances in first-line treatment, but the availability of various different lines of therapy, new treatment approaches, subsequent lines of therapy after progression in first-line treatment, and actually different interventions that can prolong life of patients. We are much more aggressive in liver resections, for instance, local regional therapies. All this sums up in incremental steps to a much longer overall survival over the last 10 years. So it's not just one effect that happened. We've never seen this imatinib and GIST-like effect that one revolution or one new drug really drove survival. We've seen the evolution of various different new treatment approaches, and that sums up to an overall survival improvement for patients.
How does the continuum of care in colorectal cancer improve the outcome of patients with colorectal cancer with metastatic disease? We have known for years now that it is very important to make available all strategies that are associated with improvement in survival, improvement in response rate, and progression-free survival in the management of patients with metastatic colorectal cancer. Even prior to the era of targeted therapy, when we had chemotherapeutic agents such as oxaliplatin, 5-FU, and irinotecan, it has been clearly shown that the ability to administer all active agents in the management of a patient with metastatic colorectal cancer contributes to the improvement in the overall survival of that patient. The availability now of many targeted agents, along with the presence of cytotoxic chemotherapy, is essential in improving the outcome of patients with colorectal cancer. The ability to administer these agents sequentially or in combination has been associated with improvements in overall survival. So nowadays we look at the molecular profile of patients, identify which agents are associated with benefit in these particular patients in a precision medicine approach, along with the integration of cytotoxic chemotherapies in patients with metastatic colorectal cancers to get the optimal benefit and the optimal outcome in those patients.
So when we think about how we're utilizing chemotherapy agents in 2020 and beyond, we really think about how we are sequencing together a number of different chemotherapies, as you heard, but also the opportunity to re-challenge and to use chemotherapy in different combinations. What we see is that the kind of classic, clean perspective of lines of therapy really rarely applies to most patients. That patients are undergoing treatment de-escalation, treatment intensification, re-challenges, alternate approaches, and that the concept of lines don't always apply. This especially is the case in the number of patients that receive local regional therapy, either surgery for oligometastatic disease, resection or radiation of the primary tumor if needed, ablation, radiation of other sites as well. And this is increasingly being incorporated into our treatment course. We're recognizing that the lines of therapy are hard to define. But having said that, we see a number of patients that will be exposed to almost all the available treatments. And for most patients, not all, but for most patients, we're really limited by the number of approved available therapies. And that it's not necessarily about the lines of therapy, but just do we have other active treatments that we can provide to them.